All right, well, we are at 12:01, so we're going to get started. I want to wish everyone a happy National Rural Health Day. I'm Sarah Anderson, and I'm the Director of Field Services at the Oregon Office of Rural Health, or ORH as we call it. I'd like to welcome you to our final bi-monthly community conversations of the year. We'll return with this series in January of 2026, so please keep your eye on our website and your emails for announcements about next year's topics in the coming weeks. I can already tell you that next year, the third Thursday in November, we will have another one of these to celebrate National Rural Health Day. ORH is really honored to celebrate National Rural Health Day with you here today. This day began in 2011 as an idea from our friends at the New York State Office of Rural Health who wanted to find a way to celebrate the power of rural across the U.S. Since the inaugural National Rural Health Day in 2011, we now set aside the third Thursday of each November to bring attention to and honor the incredible efforts of rural healthcare providers, communities, organizations, state offices of rural health, and other partners dedicated to addressing the unique needs of rural health, or excuse me, healthcare in rural America. I'd be remiss if I didn't mention that rural health is getting a lot of national attention recently. Part of HR 1 that passed in July included a silver lining, which was the provision of the largest single investment in rural health we've seen at the national level. This investment, called the Rural Health Transformation Program, will allocate $50 billion over 5 fiscal years, or $10 billion per year, beginning in January 2026. 50% of the funds will be distributed evenly among all approved states, so states with approved applications, and the other 50% will be allocated by CMS based on a variety of factors, including the state's rural population makeup, the proportion of rural health facilities in the state, the situation of certain hospitals in the state, and other factors. We're pleased to let you know that the state of Oregon submitted its application on November 4th and focused on ensuring that all people and communities in rural Oregon can achieve optimum physical, mental, and social well-being at every stage of life. The application anchors its goals in 5 categories, including improving health access and outcomes, fostering workforce innovation, so things like community health workers, supporting technological and data-driven solutions, building strategic partnerships, and ushering in a future of financial sustainability. The state was very intentional in gathering feedback from rural communities about initiatives to fund these initiatives through a public input process and submitted the application. The submitted application reflects our rural communities' priorities in Oregon. OHA proposed a 2-phase approach in the application. Phase 1, which would begin in 2026 in January, focuses on launching Catalyst Awards for projects that are ready to implement immediately. It also includes planning grants to support the development of regional partnerships and infrastructure. Phase 2 begins in 2028 and would fund larger collaborative projects that demonstrate long-term sustainability. These efforts will build on the groundwork laid in Phase 1 and will emphasize regional models, shared infrastructure, and cross-sector collaboration. If you'd like to learn more about the Rural Health Transformation Program and Oregon's plans, we invite you to join us tomorrow for our monthly policy update meeting at noon. And during this time, we'll welcome the team who wrote and submitted the Rural Health Transformation Program grant to discuss the application, next steps, and to answer your questions. Sarah is going to drop the link in the chat to both the registration for tomorrow's policy update, as well as the webpage that you can look at to see the application that OHA submitted along with a budget. So now getting back to National Rural Health Day, a significant part of the day is focused on honoring our nation's community stars. This program is coordinated by the National Organization of State Offices of Rural Health. The Community Stars Recognition Program honors individuals and organizations going above and beyond to improve rural health across the nation. From doctors, nurses, and public health leaders to hospitals, educators, emergency responders, and community-based organizations, these stars reflect the incredible people and organizations making a difference. Spanning 47 states this year, this year's Community Stars embody the power of rural through their compassion, innovation, and collaboration. Each star is selected by state offices of rural health and represent a story of leadership and resilience, proof that extraordinary things happen when rural communities come together. This year, ORH is thrilled to announce that Lisa Ladendorf, Director of Training and Consulting Programs with Northeast Oregon Network, or NEON, as Oregon's 2025 Community Star. I just got shivers for you, Lisa. For more than 30 years, Lisa has devoted her career to improving health outcomes for rural Oregonians. As the founder of NEON, she has built programs that strengthen health systems while uplifting people who rely on them the most. A licensed clinical social worker and community health worker, or CHW, Lisa has trained and mentored hundreds of health workers while continuing to provide direct services herself. She leads with compassion and a deep belief that rural communities deserve the highest quality of care. You can read more about Lisa along with other states' community stars in the booklet that Sarah put the link for in the chat just a moment ago. You can click on each state and obviously click on Oregon to read a little bit more about Lisa and to share in her honor with her. We've asked Lisa to join us here today to honor her and to hear about her rural health experience and contributions. And she's joined here today by Katie Williams and Rosie Strange. Katie is a community impact manager with the Columbia Gorge Health Council. She's a licensed practical nurse and CHW with 20 years of experience in clinical and community-based health. She played a lead role in the creation and implementation of the Bridges to Health program, which addresses barriers to health and well-being with cross-sector network of CHWs. Katie has an understanding and passion for collaborating with social service and healthcare providers to equitably serve community members. Rosie Strange is a registered tribal member of the Confederated Tribes of Warm Springs, but call themselves Indigenous to Turtle Island because their lineage to this land, North America, predates colonization with Chicanx lineage. They are a two-spirit, indigiqueer, non-gendered person. They became a project coordinator for the Aqua Tupshwa Kushna, a native support program of the Columbia Gorge Health Council in the spring of 2024. They have been a CHW along the Nichiwana on both sides of the river to access housing, food transportation, healthcare, education, and much more. Prior to CHW work, they have 15 years of experience working as a certified medical assistant in a family practices, also along with the Nichiwana. Welcome to all three of you. Thank you so much for being here to celebrate National Rural Health Day and Lisa's award with us. am going to ask Lisa, Katie, and Rosie some questions, and then we'll open it up to the audience to provide your perspectives on rural health and ask your questions. So welcome, Katie, Lisa, and Rosie, and thank you so much again for being here with us today. So first question is, can you each please tell us about why you pursued careers in rural health?
Sure, I can start. I grew up in an extremely frontier area in the Four Corners area of Arizona. And at the time I grew up there, there was no internet or telehealth or anything like that. So that dates me a little bit. And there were no doctors or dentists or hospitals or nurse practitioners or school nurses or anything like that. And the nearest medical care was about 60 miles away. And I was pretty much a wild child with no fear. So I was always injuring myself. And there were lots of 60-mile rides to the doctor with a towel holding my hand or wrapped around my arm or and anxious parents, and that kind of tuned me into what lack of access meant. It also kind of interested me in healthcare, because of, my own healthcare needs that I've had throughout my life. And I think that having grown up rural and loving rural, that's where I chose to spend my life and raise my children. And being very aware of what it meant to live in an area with no health care, I've always had that strong value for access, which is where a lot of my energy and focus and vision has been spent, is on access.
Awesome. Thank you, Lisa.
Mhm.
Rosie, how about you?
Sure. Thank you, Sarah and Lisa. I currently live in the Dalles, Oregon, and do a lot of my program work out of the Dalles, Oregon. I was born and raised here in the Columbia River Gorge. The Nichiwana is my ancestral homeland. Indigenous people have lived here since time of immemorial. And so being raised here in a rural county, um, born to parents who were brown, and my father was undocumented. I grew up going to La Clínica de Cariño, which was a rural health clinic that formed out of needs for migrant seasonal farm workers. And in that, I met a lot of community advocates and supporters that really inspired me to continue this work into my adult life. And I mean, I was a young parent looking for a stable job, and becoming a certified medical assistant is how I found my entryway into that path, into that field of work. Eventually started working at La Clínica de Cariño and really engulfed that whole connection from my own childhood to my professional life. And then working in healthcare, that frontline role as a certified medical assistant, you see where the gaps of care are. And rurally, I mean, COVID really changed that dynamic. But prior to COVID, some resources were a real struggle to find. And so that is part of why I feel called to this work. As a certified medical assistant, I always thought my care ends at the front door, but getting to find this role as a community health worker and now supporting teaching and uplifting people that are coming into this work is such a special honor, and feel so connected to my whole story as an Indigenous person, as a Chicanx person to this region, and really connecting those two things together is so special to me, and such an honor to bring my cultural needs into this work for myself, but also for my community that's around me still here. Thank you.
Thank you, Rosie. We really appreciate you sharing your story. Katie, how about you?
Yeah, thanks for having me. Hi, everyone. So I grew up in rural Oklahoma, and that's also where I started my career in healthcare. I've worked in both metro and rural communities, and I find joy in both of these communities, but I definitely prefer the deep connections that you make in rural communities. I think what I value most is being a helper wherever I am, whatever community I'm in. And I've come to understand through my work that it takes, and for rural communities, it takes a lot of creativity, the ability to like shift priorities and operate in a gray space. And that seems to be where I thrive. So that I think is what has really pushed me into finding rural communities and places to work that fit those values that I have, and where I thrive and where I can be helpful.
Awesome. Thank you, Katie. So for each of you, as you move through your careers, how have you seen the rural healthcare landscape change?
Well, I mean, there's lots of ways I think I've seen it change, but a couple things that stood out to me as I was kind of meditating on this are, um, one, I think I've actually seen more resources come in. So from the time I was a child to now, I've seen more resources come in, which is wonderful. Um, I think there were, I think I've seen more attention on the needs of rural health, more focus. So, for example, I think the work that the offices of rural health have done in states over the last 30 years has made a difference to call attention to the needs of rural health and to highlight that. Some changes I've seen since COVID are we've gone all virtual in a lot of ways, which in many ways has made it easier to collaborate and easier for rural folks to participate in state level things. I can't tell you how many times I would sit prior to COVID, I would sit on a meeting, everyone else would be in person, and I'd be dialed in by phone. And like, oh, we can get you in by phone, you don't have to drive. And you really couldn't participate. So I would end up driving a lot. And the miles on my car have really gone down. Because now, when everyone is more virtual, it really equalizes a lot of participation, I think. So it's become easier to collaborate. So one thing that I think that is somewhat unfortunate that I've seen happen is I think I've seen some of the needs of the rural communities become more severe as resources disappear and the economic base has become less stable. And I've seen the needs that we're dealing with become more severe, which is not such a positive.
Great. Thank you, Lisa. Rosie, Katie, do you have anything to add?
Go ahead, Rosie.
Are you sure? I felt like you were so ready. You were going for it.
Go for it.
I kind of want to echo what Lisa was saying, which is I feel like a lot more resources have come into rural spaces, especially in a time of COVID. I was really optimistic how quickly things could change in these systems that we saw happen in COVID. But with the current political climate that we have, there's also been quite a shift backwards, like the pendulum of progress is constantly swinging. And I feel this like pull more with the current political climate that is changing back to some of those similar narratives, people fighting each other over resources rather than looking at community needs and rural community needs. And I also think that with the levels of technology, people are able to be a little bit more introverted and able to get a lot more of their needs met without needing to access community in the same way, and thus being in these really siloed little containers of community. And so it's been evolving in really great ways. And then also we're seeing some repression back into some other places that are like having to have really challenging conversations about food equity, health equity, things that I felt that we really made strides on during the time of COVID, during a time of high crisis. And now we're almost reverting back into those same places. But I also see, especially the Gorge community, really coming together quickly. And the Gorge has a rich history of that for years. And we have been a foundational place of community health work since the 80s and 70s. So I feel really passionate that we will continue to lead in that way. And I feel really grateful for the team that I get to participate in, that we look at those things and are willing to acknowledge them and continue to move forward with that. Thank you.
Yeah, I mean, I feel like, what I've thought about this question is very similar to what I'm hearing from Lisa and Rosie. And also like seeing the smallest towns that we serve getting even smaller as people move to places that have more resources. And oftentimes when that happens, the resources that were currently there become less as well. So it becomes even harder to access needed services. And then at the same time, we see these times where there's a surplus of funding and paying attention to like what's going on in rural communities and making sure the resources are there to uplift programs like ours. And then right now, it does feel like it's like you take 2 steps forward and then you take 2 steps back, however that goes. In particular with funding cuts to Medicaid, those are already being felt across the rural health care landscape. And and really expected to get worse. And so we are bracing for that. We're going back to a place of like, not back to a place, but reaching for those skills of creativity and scrappiness to collaborate and work together to figure out like, how do we make sure that we're maintaining, if nothing else, the most vital supports for our communities as we see what the future holds.
Such an important point. Thank you. I feel like you all touched on this when during your last responses, but what are the issues you see related to rural health that keep you up at night?
Well, one we mentioned is some of the declining resources. So in Oregon, we really maximized Medicaid expansion to build out a lot of systems. And some of the progress in healthcare reform that Oregon has made about addressing the social determinants of health through Medicaid and community collaborations that are based on some of the Medicaid reform and some of the actions CCOs have done. There's a whole house of cards that could come tumbling down. And as Katie said, we're scrappy and rural, so you know, we'll regroup, but there's a lot to be lost. I think one thing that concerns me even more is what Rosie mentioned, that this is a development of isolation and entrenchment in some of our kind of S&M. And that is something, having been rural my whole life, that is really works me to a degree that I get concerned how we'll continue to have conversations and connections across that. And that keeps me up at night, because if we can keep conversing and collaborating and communicating, we can really find remedies through anything that we always have. But if we can't do that, that really concerns me.
Great. Thank you, Lisa.
I feel ready this time. That's why it came off mute. Okay, cool. This one is really important to me because I'm really passionate about my work. If you know me personally, you know that really well. And a lot of what's keeping me up at night right now is the swing back on DEI. We all are in that DEI realm. I'm an Indigenous, two-spirit, non-gendered person, so I think the risk of being a public out person who calls for equity and inclusion, that's what's keeping me up at night, like the levels of oppression that are coming back and the fear and concern about the risks of being a person in this work right now. It feels real and palpable that like ICE was in our community last week, and it's impacting not just clients, people in our community, but rippling into the way that we serve as social service providers. How am I able to show up as an Indigenous, non-gendered person when this is happening in my community and it's causing emotional trauma and stress? And I wonder that about other community health workers in this work that have those shared identities with the populations they're serving. And the risks that has come with being a frontline rural health worker since the time of its formation, which is risk of bodily harm and concerns about risks of like litigious follow-up. So that's some of what's keeping me up right now. But there's a lot. There's food. There's so many things. Thank you.
Yeah, thank you for naming that, Rosie. And a little bit of a follow-up question too is, how have you been taking care of yourself and your patients during this time? Because it is not only stressful, but it kind of gets at your identity, right? A threat to your own identity. And I'd love to hear your thoughts on how you've been taking care of yourself and your patients or clients.
Thank you for that question. I think I want to say that people like me, we come from resilient people. I can see Kendi Oldshield in this room, and I just want to call out like Indigenous people. We come from this lineage of people that have been genocided, people that have been systemically oppressed. And so I feel like it's in my culture. And I feel grateful to work at an organization that supports me in my cultural practices, as well as my identity as a person. Um, I do my best to continue to maintain community. We've been doing spiritual connections as well as community outreach. I really find a lot of relief in doing community work, but I also support myself as best I can with my spiritual practices and am continually learning. Who knows? And I think that is a lot of this is a practice of trial and error, right?
Yeah.
Thank you.
Yeah. Thank you. Katie.
Rosie oftentimes reminds all of our team to take care of ourselves and reminds us that even when in those moments when we realize that we haven't been, that it is a practice and we can't always get it perfect, but as long as we're continuing to try, that's how we show up for each other and for ourselves. But this question, this was I got to when I was reviewing these. If y'all don't know, we did get to review these. I had to take a pause because I'm like, man, this is really deep, and there are so many directions that I could go. But what I ultimately landed on is when I spend time talking to the most vulnerable community members, I'm hearing similar messages. It is things like, and this is, somewhat of a quote, that my Medicaid coverage is changing, decreasing. It will no longer cover some of the costs that Medicare doesn't cover. The increase in my Social Security is not enough to keep up. I don't know how I'm going to afford my medication and still afford rent and my bills. We already know that the instance of becoming houseless for older adults and people with disabilities is on the rise. And the idea that funding is being cut at the same time that we are seeing like this a great increase in needs, I think is what keeps me up at night the most is if we're not here to be these types of safety net programs, I mean, preventative would be best, right? But as long as you still have some of these safety net programs, we're there to catch people. And if we're not there, what happens?
Thank you. Really appreciate all of your sincere responses to that question. I know it's a difficult one to think about, and we all have those things that keep us up at night, and I appreciate your honesty and your responses. We're going to shift gears a little bit, talk a little bit more about CHWs, and what we're how they've been incorporated into rural health and where we see them going in the future. So my next question is, what's your experience with how CHWs have been incorporated into the rural health ecosystem? And along with that, what kind of impact are they having on the health outcomes of the rural residents you serve or see served?
So this question is kind of related to the last one you had on here, which is one of the most rewarding accomplishments for working in rural health. And unlike the Borders area where my colleagues and Katie and Rosie work, there were no community health workers out in the eastern region of the state. It wasn't even a term people knew anything about when we started this work. And so one of the ways I see them incorporated into our work in this area is that people went from not having any idea what a community health worker was to having them trained and putting them on the phone in the medical office to making referrals to everyone knows what a community health worker is and having them fully integrated in multiple settings. From hospitals to clinics, behavioral health to community-based organizations. And so that is a huge impact and a huge growth starting in 2012 to now, which is really when that effort started. And, some of the things that I see happening is one is that CHWs are really connectors, bridgers. I mean, if I ever say the word bridging, whether it's bridging between cultures or languages or systems, it's this fluidity and bridging that to me is so relevant. And the work that I'm going to do is life-saving. So I'd like to actually share a story when I talk about impact rather than numbers. There's a particular story that I'd like to share And this is some of our work here in Union County, is we have a large population of folks from Asia, and we were asked by the hospital to employ recreation community health workers that could provide language and culturally specific services to work with this group. And some of the challenges they were having were really some cultural differences, specifically around time and communication. So the Micronesian culture has very different way of working time than, say, a hospital clinic has a working time when it comes to appointments and how late you can be and when they're made. Transportation is often an issue for many people, and in rural areas, we don't often have available taxis or buses or that kind of thing. And many clinics have gone to a policy that says if you have 30 no-shows, you're then out of services. So it's also true that because of languages and because of this cultural piece about being assertive with folks in authority, that folks would end up from the Micronesian community with appointments scheduled for them that didn't really work for them at a time that didn't really work, but they weren't always able to say, that doesn't work for me, I can't come in. So we actually had someone, and this is a rather challenging part of the story, who had diabetes and was missing appointments and was cut off from their medical care because of missed too many appointments, who then had to have several toes amputated because their diabetes progressed too far. And that's the impact of what happens when you don't have a community health worker. Having a community health worker who could understand those systems, navigate the communication, bridge to help each side understand the culture of the communication, help the clinics understand this difference of time, help the Micronesian individual say, no, if you can't make the appointment, it's not rude to say you can't make the appointment. It's appropriate, and we need to say you can't make the appointment. Has meant much better care, particularly for those individuals with diabetes. And since this program has started, not a single individual has been quote picked out of or removed from primary care. And those folks participating are reporting high satisfaction with their primary care, which is actually probably more important because that means more trust in their primary care provider, which, as we know, results in better management of conditions. And that it's not just a matter of patient satisfaction, but what ultimately will result in, as I mentioned before, is something like as severe as amputation if you don't have that in place. So that's the kind of impacts that I think community health workers and are having.
Thank you, Lisa. What a powerful story. Before we go on, I just want to note that your sound, we could hear what you were saying, but it's a little choppy, and I'm wondering if you turn your camera off, if that might help.
Yes, sorry about that. As we know, and is that better?
It is, yes. Thank you. Yeah.
As we know, in rural areas, there might be some wind between here and there affecting my bandwidth.
Yeah, exactly. Rosie, Katie, what do you have to add?
Can we go first this time?
Yeah, go ahead.
Or next? So our Bridges to Health program is exactly what this question is, really. We are the hub for a network of community health workers that work in healthcare. We have contracted partners in healthcare, social service, community-based organizations that help decrease some of those silos that patients experience when they're trying to figure out who to talk to. How do I follow this plan of care? This referral's not calling me back. These complicated systems. Community health workers, that's oftentimes where they step in, like in Lisa's story, to help their clients better understand what's going on and how to access the services that they need. For our program, we enrolled our first client in 2017. And then in 2023, we did our most robust program evaluation, where we were able to evaluate and look at Medicaid claims data for our clients specifically. So we found that people working with a community health worker in our program had a decrease in emergency department visits. They had an increase in appropriate and preventative healthcare visits. They had a decrease in inpatient admissions and inpatient days spent in the hospital. And they had an increase in utilization of resources like non-emergency medical transportation and case management services that were offered. So I think it couples well with these really impactful stories like Lisa had, to actually then be able to put true data that really speak to, policymakers around cost savings, because keeping people out of the emergency room and out of less inpatient days is saving a lot of money with a workforce that is affordable.
Thanks, Katie. What an intro. So I was working in healthcare when community health workers came into the realm. And I will say that I feel like it's been a challenge for rural health systems to understand how to fully utilize a community health worker to their full scope. And it was met with some opposition. I remember working with what I call dinosaur doctors. So maybe elder doctors that are like aging out of this realm of work, but came from a healthcare realm that was a little bit different. What I call MacGyver medicine, where you just rurally, you figured it out. You made it work for your clients or your patients as much as possible. And working at La Clínica de Cariño, we were very much one of those health clinics that were like, well, we'll figure it out with you. But at that time, I remember some of those dinosaur doctors being very in opposition to community health workers. Like, you're not a social worker. I don't know if I can trust you the same way that I could trust a social worker. And so there was a lot of information and knowledge that had to be put into how community health workers identify themselves in this work and in these rural health spaces, how they give an elevator speech to help community partners and patients and clients understand what their role is in their health needs. And I feel like it's been having huge impacts on people, especially June, who is in this meeting as well, one of our most rural community health workers. You really start to see those impacts of people making the effort to meet people where they're at. June does a lot of driving into rural spaces and really supporting people in that, meeting them where they're at. And as a community health worker that went to INLU sites, like, I was meeting people that hadn't dealt with health issues for 10 to 15 years because they felt like they couldn't see themselves accessing that. And really that cultural bridge and connection of like, I know this is scary. I know there's historical trauma. I know that you're still barely surviving. And also, your health insurance can support you with this. Let's learn how we can do this together and collaboratively. And so it's still going on and it's still actively changing. I feel like we're in this time of like unfairness because people finally are starting to get it in a rural capacity of like how community health workers can be so supportive to like minimizing the emergency room visits, helping people get the additional care and after services they need, as well as stabilizing themselves with housing and food, is so impactful. And then we're seeing Medicaid funding change. And that feels like a blow right now. And I feel like we're constantly having that discussion of we planted the seeds and now we're just going to keep doing our best to nurture it as best we can. Thank you.
Thank you. In and among all of the challenges in the current environment, I think that really goes back to the resiliency of you all and community health workers and rural folks in general. So how do factors like transportation, geography, or limited healthcare access affect the training, excuse me, affect the training of and ultimately the work of rural community health workers?
So I think I got my audio figured out. Is this better?
Wonderful.
Thank
Yes.
you. And I'm going to say thank you to my wonderful colleague, Kenda, who always gives me an assist with technology. So I think Rosie made a very important point earlier that I'm going to second here, which is community health workers are facing many of the same issues that the people that they serve are facing. And this is something that's coming up again and again and again in the trainings that we're doing. One story that I'll share in a training that I have right now is that someone who's an executive director of a community-based organization was brought to tears in a training that we're currently doing as we were talking about social determinants of health, because she had been working unpaid for 4 months because her grants were held up with the state. Um, and, that's heartbreaking. So that's the first thing that I want to say. The second thing about training that I'll say is that although we would love to train in person, and that has been the goal for all of us, and part of the partnership that we have with the Gorge Health Council here is a training partnership, we're all still training virtually. And part of that is that although we would love to train virtually, things like childcare, transportation, it's folks can take 4 hours of their training time and not have to have childcare and be at home. And so a lot of things we're still doing virtually because it adds a little bit more ease and a little less expense into the community health worker's life, because they too are struggling with access to transportation and access to childcare just as much as the folks that they are serving are. So we try and acknowledge that, provide that support as much as we can, both in training environments and in employing environments. And one of the things that NEON has done over the last 4 years is really do a lot of training and consulting that's focused on executives and managers in organizations about workforce wellness, organizational justice, and how leaders in organizations can change their organizations to better support this workforce and all their workforce. And some of the work we've actually done with the Gorge Health Council was with the Gorge Health Council around some transformative policy work that they did to change their workforce to be better for their staff. So I'll kind of end there with that.
That's great. Thank you, Lisa. I have to tell you how appreciative we are that your CHW trainings are all virtual. We've tried to recruit to hybrid or virtual, and the majority of the people prefer virtual because we're working with statewide, statewide,
Mhm.
and folks can't travel hours to a
Yeah.
training. And so we really, really appreciate that commitment. Rosie, Katie.
Sure. So lots of factors there. Transportation, geography, limited access. Whew, such a hefty question. I think it definitely impacts community health work outside of the training space. When I started as a community health worker, I was driving 2,000 to 2,500 miles a month for outreach, because I would do outreach for like a span of Cascade Locks all the way out to past Rufus, because that's our county spaces, and that's where Native people are living. And so they're not having access to infrastructure such as a busing system that you would find in a metro space. And so we do have to go to them. And the majority of clients that I'm serving don't even have phones. So it adds like a real level of complexity. Definitely allows so much space for advocacy, right? Like highlighting, I appreciate that you all have a non-emergency medical transport system, but did you know that it actually doesn't go to the INLU sites? And having to have that conversation with OHA, with Pacific Source, with Medicaid to say, like, this all sounds great on a paper level, but the people that are being able to access it are really struggling. And our role is so important in that advocacy, like acknowledging what a challenge it is for people to find childcare in a rural space, to find food resources in a community that has 50 people of a population, like looking at just the complexity of that and such long distances. I think that it's a real challenge, and it's coming into light even more with everything changing so quickly funding wise. We really relied on Pacific Source Flex funds to help fill those gaps of the rural needs, and seeing that shift so quickly has been a real big growth point for us. So thank you.
From a quick follow-up question, from a policy perspective, I know that it's been a challenge to get drive time or windshield time, as folks call it, paid for. In addition to the actual service with the patient. Have you been able to overcome that barrier at all, or is that still a policy lever we're working on?
So my organization does pay mileage, but I did work at a partner organization that was paying below the federal limit when I was driving that much. It definitely is still a challenge for a lot of community health workers. But I think Lisa even really pointed out we are bleeding hearts for our work. Often we are working without pay and without that reimbursement. And especially now that I'm more in a leadership role, I advocate in our region for wages for community health workers and for those policy things to be in place to support their outreach needs as much as I can. So it definitely is still a challenge. Thank you.
And so what I will say to that is that many organizations are paying staff for drive time. So for example, our organization pays staff for drive time. A lot of our advocacy work we do with other organizations is to pay staff for drive time, but the organizations do not get any kind of allowed reimbursement in the billing for drive time. So if you're looking at billing for a service, then unless the patient is in the car with you, you can't get any kind of billing for the drive time. So that's where the financial impact comes. And if you look at a rural health clinic can get enhanced reimbursement rates, but a community-based organization such as NEON or such as the Columbia Gorge Health Council, Bridges to Health, we are just, a lot of times we can't even get Medicaid contracts directly. And NEON is unusual as a community-based organization for having that. And there are certainly no there are certainly no enhanced rates like a rural health clinic might have for that to compensate for drive times. So that's still an issue, even if the staff is paid for that for the organization.
Okay, thank you. Katie.
Yeah, I mean, I don't know that I have anything to say that's not very similar to what's already been said. I think when we think about transportation, if it's challenging for this like staff and workers to get to the far reaches of our counties, which for Wasco can be close to 2 hours, we can't expect our clients and our community members to get to the service, to be able to drive that far to get to the services. So yes, our organization has been lucky so far around having the connection we have to the CCO, robust funding for Medicaid. That's how a lot of our work is paid for. That is quickly changing. And I think we pay our community health workers a living wage. We did a wage analysis, and yeah, it works out really well. And people have not left our organization in quite some time. I think that speaks to that. Also, with the mileage reimbursement that we provide, we match the federal rate. So providing the resources for our community health workers to be able to fully do the work. And then I think it takes, in my opinion, hiring someone who's from the community they're going to be serving, so they already understand the landscape of where they're going to be working and the challenges that they're going to be facing. And then it takes a certain amount of grit and creativity again. And to second what Rosie said, CHWs help people understand what resources are available, how to access them, being honest about what's not available, and that voice to call out the gaps to larger systems to say, hey, this isn't actually working for everyone. And then around policy, I know we have that question later, but similarly to Lisa, it was, for me, it's around Medicaid reimbursement rates for the work that community health workers are doing to make those really cover the cost.
Great, thank you.
And
And
final thing that I will
go ahead.
add to that is just the OHA does a workforce analysis assessment every 2 years, and it reveals that community health workers tend to leave the field within 5 years. And a lot of that has to do with the wages paid and the sustainability of the work for them.
And I'm going to give you a chance to talk about policy now due to time, because we have 10 minutes left. We're going to do 7 and 8. I'm going to go with 8 first since we sort of teed that up already. So how do you see the work of CHWs in rural Oregon evolving into the future? And are there any policy steps or levers that need to be taken or implemented to help advance their work?
Yeah, so there's one in particular, as a training director and someone highly invested in workforce, there's one in particular that that I strongly advocate for and would love to see, and that those are advanced credentials for community health workers. So CADCs, chemical dependency counselors have advanced credentials, qualified mental health associates have advanced credentials, and we would love to see community health workers having advanced credentials. As a matter of fact, amongst our training collaborative, we've talked about a physical health, a behavioral health, a housing navigation. Those are all areas for advanced training where we'd love to see the state have advanced credentials in that. And yes, there would be policy changes connected to that. One would be some policy changes to structure allowing for that. What would be the training requirements for that? What would be the certification for that? That would then promote higher wages and an upward trajectory and promotional path. Most community health workers that leave may leave for higher wages and career trajectory development. They don't necessarily want to leave community health work when you talk to them. So we have to find a way within community health for a career path development, which this would do. The second thing that would really need to be associated with that to support that are expanded billing codes that would support the work of advanced certification for community health workers. That would also require some policy changes.
Great, thank you. Katie, how about you?
Well, I mean, I actually was thinking a lot of similar lines to Lisa. Imagine that. But I mean, our organization, we are working on some initiatives around a pathway to higher education for community traditional health workers in particular, like a homegrown pipeline. It's called our Behavioral Health Consortium. We also lifted up with the help of Neon contracting with us to start our learning collaborative, which is something that Rosie leads. And we're training rural community health workers, and then hopefully also providing a path to higher education, like Lisa mentioned. Yeah, I think those are our biggest initiatives right now to advancing community health work. Yeah, go ahead, Rosie, if you want to speak to like the training hub.
Yeah, our training hub launched earlier this year with the support of Neon, and I think that that is something that we're all really passionate about, is putting out and supporting quality community health workers finding their way into this field, as well as we hope to eventually develop some curriculum for how community partners can engage and fully utilize community health workers to their full scope, to offer that consultation piece of like, let's look at how you can be training your staff to utilize a community health worker to that full capacity, helping health systems understand how to communicate with community resources around their needs for community health workers. I also have had the honor to be a part of some of the tribal billing conversations, and I know that OHA and CCOs of Oregon really value that piece. It relates closely to community health work, but is a different vein of it. And then, yeah, echoing what Katie said, the Mental Health Consortium. I know that our executive director has high hopes for pathways to additional licensure that can really support long-term career path of community health workers and keeping them in this work so we can see their voices reach far. Thank you.
Great. taking notes. All right, and final question is, please tell us about the current projects or initiatives you're working on to advance community health and CHW training in rural Oregon. So maybe a little bit more discussion about the hub and what's going on there.
Yeah, so within the last year, NEON, in conjunction with partners, the Columbia Gorge Health Counselor and Bridges to Health being one of them, Mid-Willamette Valley Community Action Agency being the other, and then Conference on Local Health Officials was a supporting partner, launched a training hub. And this essentially, we also worked with the Office of Equity and Inclusion to sort of get approval for this. And it's really to work with local community organizations to use NEON's curriculums, working under NEON's training program, training approval through the Office of Equity and Inclusion, and also utilizing our marketing expertise, our learning management system, landscape, landing page, website page and design, billing infrastructure, to help folks launch some local training efforts that can be more responsive to the communities, culturally specific to the communities. And then in our training program, we don't just train folks and say goodbye. We really try and stay connected with everyone, not just to us, but have them stay connected to one another, to build communities of practice and support. And that's going to be easier to do if the geography that they're spanning is smaller and the trainers are local. So it's also true that many training programs would get approved and then not continue providing services, because the fact of the matter is it's hard to specialize in the business of running a training program and the pieces about keeping a curriculum updated and how do you price things and what's the marketing like and the logistics and technicality of learning management systems. So when we're able to provide that support, that allows the organizations that are working with us to focus on the curriculum, the facilitation, and the relationships with the local CHWs that they're training. It also helps us in NEON in terms of helps us improve our curriculums. We get feedback from trainers, wider populations. We hear about what folks are needing. There are more partners and facilitators to work with in developing new curriculums. So it really extends and expands our ability to work as well. So that's one effort. We also, through the hub, are bringing folks in through our training. So Planned Parenthood has offered trainings through us. I see someone on here, Erin, who has the palliative care training that we're talking about, bringing that training through NEON as well, so that through these collaborations and partnerships, we're really able to reach and provide CHWs with some high quality work that none of us as single entities really would have the capacity to do on our own.
Great, thank you. And I would be remiss if I didn't mention the work that the Office of Rural Health is doing to support community health workers too. So we worked with the Oregon Coalition of Local Health Officials to train up 300 and cross-train 300 community health workers. That funding ended in July, but we continue to train cohorts through some funds from OHA as well. And then we have a listserv and community health worker peer group that rural community health workers, specifically peer group, that our rural population health program manager, Stefa Dragoon, runs. The listserv is just two-way communication about opportunities, questions folks have, and then there's a monthly meeting. I'll put the link in the chat just so that you all know about that as well.
And I would also say if anyone is interested in partnering in the hub or interested in talking about partnering on trainings or how to access this, they can feel free to reach out to me and I'm happy to talk.
Great, thank you. All right, we are at 1 o'clock. Any last comments?
Just thank you so much for inviting us all to talk today. I think the last thing I would say, or that any of us say that we love about the power of rural, really is partnerships and collaboration. And that is where the secret sauce lies and what we all love do. And I think where our hope lies for what's ahead of us.
Love that. Thank you so much. And thank you, Rosie, Katie, Lisa. Congratulations again, Lisa, on being a
you.
community star. It's clear why you were chosen as a community star and your commitment to rural health and improving the health of others. And really appreciate all three of you being here with us today. Happy National Rural Health Day, everyone. I hope you have a good rest of the day.
Thank you. Congratulations, Lisa.
Thank you.
Thank you.
Thanks, Candy. Nice to see you.
Congratulations, Lisa. Thank you.
Moon.
It was good to see you too, Rosie. Bye.